Good afternoon, all. Good afternoon, sir. Shall we start? Okay, so we are having our 15th session of Foundation course in Palliative Care today. Thank you for joining us on this busy evening. Thank you all. We have Dr. M. Rajagopal as our faculty here. I think there is no need of further introduction for him. We are familiar with him from our last session. Welcome you, sir. Welcome on board. And we are honored to have you here. Thank you so much. And over to you. Sir, you're muted. Sir, please unmute.
Thank you very much, everybody. Hello. Hi. Senior, what was the number of participants?
Around 40, sir. I think some of them are still joining.
We have only 17 and our team will make up about 3 of them. So only some 14 participants. And even among the participants, only 3 or 4 are showing their face. Otherwise, it's rather discouraging. Dark screens in front of them. Black generally signifies sorrow, unhappiness. Oh, thank you. Thank you very much. Alice, Pavan, thank you for switching on the video. So, hello everybody. We are going to talk about death and dying. An international organization does a program every year. They call it, let's have dinner and talk about death. People just get around talking about that. There is another program called Death Cafe. Some of you might have heard about that. In a Death Cafe, a few people, deliberately 3 or 4 people, sit in a cafe and just start talking about death. And there's one unfailing phenomenon. People who are overhearing it, many of them will ignore it, but some people will come forward and say, hey, I heard you talking about death. Can I join you? And in about 15 minutes, it swells to a group of some 20 people. The fact is, in our society, there are those people who feel a lot about death and dying, who have experience in it. And here among the 20 people who have joined us, I guess that there will be at least 6 or 7 who have gone through the experience of a loved one dying in your own family. If you have had that experience, some of you, would you like to raise your hands, either electronically or manually? Purnima, Alice, maybe some of those dark screens also may come up, and some hands are rather slow to come up in this kind of question because you don't know what is going to come. Will I start asking you to talk about it? And this may not be an easy subject to talk about it. I'm not going to force anybody to speak. Rajiv, yes, thank you. Let me ask you another question. For this, I would like a response on the chat box. Question to the 24 people who have joined us by now. Are you able to think about your own death? The answers could be yes, no, or not sure. Senior, will you take a count?
Sir. Most of the answers are yes.
Yes, that doesn't mean that most of the people say yes.
Only one no.
That means how many?
Only one no.
That means people who are able to say yes are able to say yes immediately. That others are not sure or they don't want to say that, say no. So how many yeses have you got? And how many no's? It is not anybody's fault. It's not an easy subject to think about.
Around 15 yes and 1 no.
And that leaves out another 8
Yes.
who haven't answered or who are not sure.
Again, yeses are coming, sir.
Okay, very good. I mean, this group particularly, ordinarily, if I go and ask this to a group of doctors or medical students, I will not get more than 1/3 of yes, almost invariably. If I go to a group of lay human beings and ask, more people are able to say yes. No, the question did not come from me just to trouble you. There is a reason why I asked that question. Let me share my screen and share with you what I have to say on that subject. We are going to talk about the care at the end of life. And of the people who shared, majority are able to think about your own death. In a moment, I'll explain why I asked that question. You have had this discussion. Many of you knew already, others might have come across this during previous discussions, right? Senior, the reactions to grief was covered already?
Yes, sir. This is our second last session. One more session is pending.
Okay. So I am sure you would have gone through this, right? The Elizabeth Kubler-Ross description of the 5 stages of grief, how you react to a bad situation with denial, anger, bargaining, depression, and acceptance. The 15 people who said yes have one major strength. They are in acceptance of their own mortality. They are able to meet with death, not necessarily with pleasure, but know that it will happen someday. That's a level of acceptance. Those who find it either no or not sure, that may make life a bit harder for them, especially when you are trying to help people who are dying. The best time to contemplate your own death is now. You are all young people. Everyone here is 1 or 2 generations below me. It's unlikely to happen to you in your near future. Then why should you think about it? One, it will help you to value life. Being able to think about your tentative existence in this world helps you to live your life more meaningfully. Senior is a NECO coordinator. She is not a direct palliative care provider. But sitting in this room, she has been forced to think about pain and death. Maybe for the first session, she would have had this impulse, I don't know, to run away. But what I mean by valuing life and living meaningfully can be best illustrated by a Bhutanese custom. Bhutan people are almost all Buddhists. And they have this ritual that 5 times a day, they have to think of their own mortality. How horrible you may think, how morbid. But you must remember that till the recent invasion by Western culture, the Bhutanese people, who were by no means the richest in the world, they were the happiest people on earth. When in the early 1990s, the world brought out the global happiness index, the concept and a way of measuring it, Bhutan came first. There may be many reasons. Certainly it's not money. They were not the richest by any means. They were a low middle income country. But this is the crux. When I am able to accept that I am likely to die, it can be today, it can be 15 years later, whenever. The fact that I may die means that I am able to think about what is important. Have you thought about it? What is that you plan to do with your own wild and precious life? That's a poem from Mary Oliver. What is it you plan to do with your own wild and precious life? I'll stop the share so that for a minute so that I can talk to you directly. Maybe you have never thought. I mean, you have just gone along with the stream, appearing for one exam after another, then getting married, having children, or planning all that. What is it you plan to do with your one wild and precious life? When you know that you are mortal, you are able to think about it. And Manath, Anita, Anima, Vinu, maybe this evening, while you are waiting for your daily roti, you may give this a thought. What is it that you are planning to do with this wild and precious life? What do you want to achieve? What would you focus on? Certainly you want to look after children, give them a good future. And then, of course, it would be nice to have a bigger house to live in. Well, not exactly a Mercedes, but still it would be comfortable to have a wider car. Maybe those are the kinds of thought that will change. When you try to answer this question, what is it you plan to do with your one wild and precious life? When you think about your mortality, you are able to think about these kind of questions, and more importantly, you are able, or equally importantly, you are not only able to think about these things, you are able to help others. Sorry. If you are not able to face your own mortality, it will be difficult to help others who are dying. It will help you not only to value life and live meaningfully, it will also help you to die as well as possible. Let me explain why. When my time comes, where am I likely to die? I am not very rich, but I am comfortably off. I'm okay. I get a substantial monthly pension. My wife gets a pension and we are okay. Money may not be such an issue. Where am I likely to die? Sunanda, what do you think?
Difficult questions are for me at least. So.
No. I mean, of course, I am immortal. This is not something reasonable. Just imagine. Okay, take away me. No, you are not worried about. You are worried about me. Just take another retired doctor. Somebody else, anonymous. Where is he or she likely to die in?
Definitely in their own homes with their family members around.
Really, Sunanda?
Yeah.
Sunanda, no. I may die in my own home, but more than 90% of doctors die in intensive care units. Separated from the family with a tube in every orifice. which you try to pull out, so they tie your hands and feet up. It's not done even to the people in solitary imprisonment in prisons. Even people who are, they're not changed inside the room. So, Sunanda, that is not what happens. Anybody with a little bit of money in the pocket nowadays dies in the ICU unless the person has done what I did. Prepare my own advance directive. Discuss it with my wife. Discuss it with my children. And when one of them said, no, don't want to talk about these inauspicious things, I requested him to drive me to a meeting where one person was talking about end of life care. He heard the session, and as he was driving me back, he said, I now understand what you mean. It's okay. I said, if you are able to think about your own mortality, you will learn to value life and live more meaningfully. You will be able to help others who are facing death because now you will understand them. And not only that, that preparation will help you to die as well as possible, because this depends on every one of us more than anybody else. I'm sure from all the furrowed eyebrows and thoughtful faces, I suspect that some people want to ask questions or say something. Comments, please. Anybody? Quick comments. Anita, Lani, Rosemary, Resi, Aarti, Shweta, somebody say something.
So can I say something?
Who is this? Sunanda.
Sunanda.
Yes, Sunanda.
So actually, I agree with you. You talked about the reality, what happens, but as a wish, I think everybody wants to die, in the homes and with family. But what you rightly said is that at the time of taking a decision, we don't really ask the person concerned what is his or her wish. So that's what I wanted to share. So thank you.
Anybody else?
Yes. Yeah, talking about considering the end of life, thinking about it, my personal belief and perspective is based on my Christian faith, and I am very comfortable with that in terms of thinking about it or knowing what will happen to me after that. But how I die or how will it end, even as Sunanda mentioned, we all wish a peaceful and and at the end of like, again, we don't know when. So how and when is decided by God. So even whatever we wish, it doesn't carry much, but at the same time there are some reasonable expectation that we can expect for ourselves, is in the sense to take care of ourselves the best we can, so that like, you don't end up with illness or sickness or anything of that kind, and so on. So in other words, to summarize it, I have a positive thinking in terms of and expectation, and when I think about it, I'm not worried, or I'm not panicking or anything of that kind. So that is my view on end of life.
You are Sajjan or Sajan?
Sajjan.
Sajjan, good. Thank you for that contribution, and I'm glad. I admire your peace of mind and your religion giving you peace of mind. But in between your conversation, you said you expect to be healthy all through life, no diseases.
Living in this kind of
Sajjan, that is not reality. In this world, as you believe, governed by God, That's not what happens.
Correct.
Whether
I mean to
hope-
say, illness and sickness are all part of it, but
Yes.
like a part of life.
Mm.
But as much as we can from our side to take care of our health,
Mm.
like
yeah.
no,
Okay.
that is the best we can do ourselves, because unexpected things nobody can expect, nobody can predict it. But whatever body as God has given to us, I think if we take care of it the best we can, uh, whatever way, healthy diet and exercise and all those things, so we can reasonably expect that it will be okay, kind of.
You cannot reasonably expect that you will be okay if you exercise. And I'm sorry to disillusion you. That's not what happens in this life. Many people. How about children who get cancer? How about people living great lives and then still getting many diseases? Sajan, I'm sorry to disillusion you. That's not the real world. I am saying that even with all your good habits, you may avoid many lifestyle diseases. But many things come uninvited. And at any point of time, only 10% of all of us will die a sudden death. 90% of us will go through some prolonged illness. Sorry to scare you all. 90% of us, whether you call it God's will or God's punishment or what, 90% of humans will go through a prolonged illness, at least one, before they die. What we can do is just not do anything at all, in which case you die on a ventilator. That's the point I am making. Or, and is God willing that everybody should go on a ventilator? That cannot be true. That is not fitting in with any religious faith. Whatever your faith is, you said we have to exercise, we have to live a healthy life. Yes, equally important, I believe, that if you are to avoid that consequence of end of life, in modern, this is only in this generation. Since the turn of the century, even till 1990, this was not the case. The Indian ritual of everybody going on a ventilator, I will say why I am saying it's the Indian ritual, is only about 30 years old. Sajal, your face registers many questions. Maybe at the end of our session, we'll come back to your doubts and discuss them again. You, now that you have undergone this course, I believe, will consider yourself a healthcare provider. Everyone is a healthcare provider to your own family members who are ill. And this is the duty of care of the healthcare provider as defined by bioethics unit of ICMR. The duty of the healthcare provider, doctor, nurse, volunteer, anybody, is to mitigate suffering. It is to cure sometimes, to relieve often, and to comfort always. There exists no exception to this rule. The duty of the healthcare provider is to mitigate suffering. And unfortunately, this is about our country. This is about what Dr. Sankha Mitra, who does amazing work in Eastern India, who works in Australia to make money so that he can spend it for suffering people in our country. He says, in this country, the poor die in misery of neglect, the middle class die in misery of ignorance, the rich die in misery on ventilators. No one gets a pain-free and dignified death. And friends, unfortunately, this is true for at least 96% of our population. Sorry to paint this grim picture. This is what we all have to change. What do we want? What do I want at the end of my life? I would like to be comfortable. Physically, emotionally, socially, and spiritually. Physically, I deliberately put first, because if you have overwhelming suffering from pain, if you are unable to take a breath, you cannot think about other domains of life. Pain and physical suffering becomes overpowering and overwhelming, leaving no space for other human emotions. Social, your relationships. For most of us, or all of us, the relationships that we hold are precious. Your loved ones, people who care for you, people you care for, those relationships, your friends, the extended family, the community around them, around you, all that is big part of your social domain. Of course, emotionally, if everybody has such frame of mind, this is it. So much I have to do, the other I leave to God. He will take care of it. Perfect peace. Emotionally and spiritually. Being in acceptance is a major part of it. Those who are in denial, anger, bargaining, or depression suffer enormously. Those who are not able to think about it are likely to suffer more. That unfortunately is so. Remember that each one of them causes the other. They are all encroach into each other's circle. So generally, when I see somebody in significant physical distress, like agonizing pain, my first priority is to take care of that, but then also to look at the other domains of suffering. At this point of time, when somebody is clearly towards the end of life, where the disease-focused treatment is no longer relevant, where it's a question of time before the person dies, then unfortunately, some of the hospitals continue to look after organs. Parthasarathi Shom is a famous economist. He was chief advisor to former Prime Minister of India. And he wrote an angry letter in the Financial Times after the death of his mother. On the last day, they had all told him that she has no chance of recovery. She was dying in an intensive care unit. And the last day when he was allowed in, he saw a doctor, a junior doctor, poking her with a needle to draw a blood sample. He asked, what was it for? She said, that's for a liver function test. He asked, but you said she has no chance of recovery. Then why are you doing it? She said, we have to keep trying to the last moment of anybody's life. Trying what? To keep the organs healthy? Who can die with all organs healthy unless it's a sudden accident? Unfortunately, the medical system in the face of dying has lost its focus. When they come to us after our discussions, after the person has clearly expressed his wishes, depending on that, in consultation with the family, we would call it shared decision making. All unnecessary investigations are stopped. The vitamin and mineral preparations are of no use. You can only put them into the stomach to trouble the stomach. They cannot be used by the cells. It's a joke to continue to give the person cholesterol medication. Actually, at least 15% of people, it causes clouding of the mind. They feel better when it's stopped. And certainly invasive procedures, including that drawing another poke of needle, if it is not absolutely essential, is to be avoided. Are you comfortable with this thought? Instead, what you can do is, even if, sorry,
Sorry to interrupt, Mr. Srinivas has raised his
Srinivas,
hand.
yes, please. Sorry, I did not see your hand raised.
No, sir. No, sir. You asked me whether everyone is. I said yes.
Okay.
Yeah, yeah, yeah.
Okay. You can lower your hand. Yes, Srinivas. So we will assume, even in an apparently unconscious person, you will assume that the person can hear. You don't know. The person is unable to speak, is apparently unconscious. You don't know whether some level of conscious inside. It's good to talk to the person, exchange information. Papa, your brother and sister had come to visit you. You were sleeping. And this was happening and that's happening. I am here, Papa. A conversation like that, what's the harm? Sometimes people are able to comprehend. A person who woke up after 3 months of being unable, the person who woke up a couple of days after a stroke and then was unable to vocalize for 3 months said, the worst thing about the 3 months was that nobody told him what had happened. He couldn't ask. I suppose if somebody had given him a pad and a pen, he would have tried to write something with his left hand, but nobody thought about it. 3 months of not knowing what has happened, unable to speak. In an ICU, keep communicating. Health and emotional needs of the carer and family are so important. It's very often forgotten. They are called bystanders in India. I think only our country has bystanders. People who are destined to stand forever. Always being barked at. Thrown out of the ward when the rounds happen. Come back. They are asked to do things. But nobody asks them what they feel, what they are suffering. There must be some people who have gone through that journey. Do you think the suffering of a caregiver can be more than that of the person with the disease? Is there a possibility? Sunanda nodded. Can somebody else try to answer that question? Do you think a caregiver's suffering can be more than that of the person with the disease?
Yes, sir. I agree that it would be 10 times more than
It can be.
one.
We won't say that it
Yeah.
is always so. Vinod also says yes. Sometimes it can be. That's partly because of social situation, partly because the person who is still lies there, it is the neighbor who is demanding money, the money that they had borrowed, coming and abusing the person every day, and the children being denied everything, not even enough to feed the children. The caregiver sometimes has to live with all that. So it's so very important to look into the caregiver's suffering. And of course, if there are religious rites to be facilitated, so very important for us to do it. Somebody asks for a last communion. And sometimes an ICU says no, nobody else can enter the ICU. And you cannot imagine any healthcare worse than that. Whatever is important to that person at that point of time has to be facilitated. And every one of us, let us be conscious of the children as caregivers. Children are sometimes forced into the role of caregivers. Happening more and more nowadays. It never happened in joint families of old ages. Now that we have nuclear families, a parent is in a Gulf country, another parent is here and ill, children become automatic caregivers. Or a parent is dead, another parent gets ill, children have to be caregivers. I saw this child. Sunanda, this was in our own children's palliative care clinic in the government hospital. This child, 1.5 years, had agonizing pain. Practically not fully conscious, for following meningitis and muscle spasms. So much of pain that the child never slept for more than 15 minutes at a time, at a stretch. The mother had gone completely lost her mind. The father was running around trying to find money for this and that. This 10-year-old girl had effectively become the mother. I had asked her, do you get any sleep? She said, whenever baby sleeps, I also sleep. How long does the baby sleep? Maybe 15 minutes at a time. Her schooling was interrupted. If we had not intervened, it was not only this life that would have been destroyed, the whole family would have been wiped out. Always ask about children. And in your own families, when there is an illness, remember the children. Nobody talks to them. Oh, he's after all, he's a small boy. Oh, she's a little girl. What does she know? But they go about with questions. Grandfather is dying. Will my father also die? Will my mother also die? Who will look after me? Who will give me food? How can I live alone? These questions crop up. They try to answer them. Somebody scolds them. Don't talk about these inauspicious things. Nothing will happen to you. That doesn't answer their question. They live with these fears. And when it happens at a vulnerable age like her, it leaves scars in the mind, which can be permanent. Hey, somebody do me a favor and read this. This is from a newspaper article written by a person by name Sindhu, a journalist, writing about her father's intensive care experience.
This was by Sindhu S. in the Hindu newspaper on September 8, 2016. My 84-year-old father, my best friend, was enduring intrusive medical procedures against his own wish, all skin and bones. He looked defenseless at the mercy of doctors, vulnerable and agonized.
Our National Cancer Grid. National Cancer Grid is a collaborative of more than 200 cancer institutions in the country. They have brought out guidelines. In this document, which is available for free download, Senior, you will be sharing my whole presentation with everybody.
Yes, sir.
The link is given here. They have given 10 low value or harmful practices that should be avoided in cancer care, and one of them is do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. Despite this, 90% of people with advanced cancer die in intensive care units if they have any money in the pocket. It's only the poor that die in their homes or in hospital wards. And when we talk about withdrawing artificial life support or withholding it, let us make a clear distinction between that and euthanasia. Again, if you are not convinced, I would encourage you to give this very detailed document. You can read just the executive summary if you like. It's from ICMR. The difference between euthanasia and withdrawal of artificial life support is in euthanasia, there is an intention to end life. Is that clear? In euthanasia, there is an intention to kill somebody with a good intention. The intention is to relieve suffering, but it involves killing somebody. Withdrawal of artificial life support is just allowing natural death. It's also only preventing something unnatural being done to prolong the dying process. You see the difference? Are you comfortable with the difference? Now, the Supreme Court in its verdict, and in 2018 and following that in several documents, the term passive euthanasia was used for withdrawal of artificial life support. You read this document and you will see why it's a misnomer. Because In euthanasia, there is an intention deliberately to kill someone, passively or actively. That intention is not there. We are just facilitating, you may call it God's will, or facilitating a natural death. This distinction is important. Let's think about it. You may need time to reflect on it, but that distinction has to be clearly understood. Now, earlier I said this intensive care death of this sort is an Indian phenomenon. In Europe, Western Europe, the England and UK and the European Union countries, there, if two doctors agree that continuation of artificial life support is useless, and if the person has expressed willingness and if the family is agreeable, they withdraw artificial life support, allow a natural death, provide palliative care instead of that to relieve any suffering. And that happens in 90% of people, and only roughly 10% of people would die on artificial life support. Strangely, in our poor country, once somebody goes into an intensive care unit, 70% of them die on a ventilator or on artificial life support. Only 30% of them have it withdrawn. What a paradox. You are forcing expensive treatment that causes unbelievable suffering on this 70% of people. This is why I call it an Indian phenomenon. It's not global. I protected myself against this by writing my advance directive. This has been validated by the Supreme Court order that if I have written my advance directive, express my wishes, ask my family to take decisions on behalf of me, or somebody else to take decisions for me, doctors have an ethical and legal duty to respect my wishes. Oh, the Supreme Court has also put in some impractical procedures like writing it and having it notarized and getting it signed by a first-class magistrate, etc. But you see the principle. My wishes are paramount. You have talked about ethics on another day. You have talked about autonomy. This is my way. I am the ultimate authority of this. So remember that in our country now, though we do not have a law covering it, from the Supreme Court judgment that will be valid till there is a law on the subject, advance directives are legally valid. But Sindhu, hey, who was reading it? Was it Srinivas? Continue to read that sentence, please.
But I did not want to infuriate the doctors in those hands we had surrendered his body, and who had broken down his body into isolated segments only they could put back together again, if at all.
What she means by isolated segments is one person was looking after his kidney, another was looking after his heart. His organs were being treated by different specialists. Nobody was treating him. Nobody was giving attention to his suffering. This is something that must change. I'll remind you of the ACMR's definition of duty of the healthcare provider. It is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. And there exists no exception to this rule. And how will be achieved is by integration of palliative care into healthcare, including into intensive care. If their artificial life support is to be withdrawn, you have to give them comfort care. And this has to be done at primary, secondary, and tertiary levels across the continuum of care, that is from the beginning of the time of diagnosis to the end. And a recent Lancet Commission recommendation, I put in the reference in my slide number 1. Says this is 2021. The management of suffering should sit alongside, 2022, should sit alongside the extension of suffering as a goal, extension of life as a goal of healthcare services. Medical treatment treats diseases, cures diseases, even if not cured, say hypertension, diabetes, etc., are controlled, and extension of life is a goal. But that should be along with management of suffering. And what we are doing now, education on death, dying, and end of life care, should be in the curriculum of every health and social care student, and of continuing education for practicing professionals. And patients and families should be provided with clear information about the uncertainties as well as the potential benefits, risks, and harms of interventions in potentially life-limiting illness to enable more informed choices. Any comments there? Sorry. Here are the barriers to decent end-of-life care. Doctors think that they have a duty to prolong life at all costs, which means they have a duty to prolong the heartbeat, or keep the lungs ventilated, or the kidneys dialyzed. Families sometimes have a selfish kind of love. I can't let my father go. I can't let my mother go. I need him. I need her. The social acceptance of death in the ICU has already happened in India. People have started asking, hey, why don't we see not in an ICU? As if that's the best place to die. And the legal lack of clarity, because India does not have a law, and because the Supreme Court has put in very impractical procedures, the situation is not very nice. But most importantly, what we need is death literacy. That may seem an odd word. But friends, you should know that people of my generation grew up familiar with death. Cattle were dying in their sheds. Elders were dying in the homes. And we were not sent away. We all grew up seeing death as a part of life. But today, in nuclear families, death has become a stranger. So that same Lancet Commission that I talked about, the reference in the first slide, says we need a sustained concerted effort with media partners to bring death back into life, so that we think about death, we are ready for it when it becomes inevitable. The government had proposed an end-of-life care law in 2016, but it did not happen, and the government changed. Once, even if it's the same party, once the new government comes in, old proposed legislation is invalid. So today we have to go by the Supreme Court of India's legislative order. According to this, advanced directives are valid. Withholding and withdrawing life support is permissible, but there is an impractical and complicated process. And unfortunately, the court order caused withdrawal of life support, passive euthanasia. This has also created a problem. I'll stop there. We have 11 minutes, I see, for any questions or answers. I'm sure there must be many. Can I ask anybody who has not spoken so far, please say something. Sajjan spoke, Srinivas spoke, Sunanda spoke. Who has not spoken? Please say, if you have a comment or a question in your mind, please say it.
I have a question. How can we convince the subspecialists not to offer unnecessary treatment during the end of life of our patient.
So how can we persuade specialists? Is that the question?
Yes, because
Le-
here in the Philippines, by the way, I am Dr. Lani from the Philippines. We started our palliative care in the Philippines, pediatric palliative care, last 2020. And I finished my pediatric palliative care fellowship last year. So we are now
That
implementing
Where
our
did you do
program.
it from?
Yeah, from it's a hybrid fellowship
Hyderabad.
training program from
Okay.
a joint program of Two Worlds Cancer and
Yes,
Hyderabad.
I know the program. Yes.
Yeah, yeah.
Uh,
So we are now implementing the pediatric palliative care program. However, our challenges now is some subspecialists, particularly the oncologists and hematologists, they are still offering too many treatments for patients who are like in leukemia, who are refractory. They are still offering other treatments.
Lani, can I ask you, what's your own answer to your question? How can we? These are all doctors with many, many degrees. You are a medical doctor, right? Yourself.
Yes, I am a pediatrician.
Okay, okay. So if there is a pediatric oncologist or a pediatric cardiologist on the other side of the table, Lani being a young, not super specialist doctor is pretty powerless. So what do you think will change it? One good thing to take is take up a big hammer and strike them over the head, which may have invite legal complications. You can't do that. What else can you do? How can you persuade them? What do you think? Your own answer?
What we are doing is just conducting a multidisciplinary meeting or conference. However, still we are having challenges because there are a lot of subspecialists who are not aware with the pediatric palliative care. So still, I don't know how to convince other subspecialists. We are promoting and communicating them. We are constantly communicating with them to plan and set our goals for the patient. However, there are some that would not accept our goals of care because they have other plan of treatment.
Lani, my heart goes out to you, of course. You are in a difficult situation. What you are doing is try to talk to them and persuade them to see the light, which is very difficult. When you have 3 or 4 degrees, you are like a full cup, full of knowledge, disease-specific knowledge. You are unable to take in any more knowledge. The strategy is only, they will change only when the societal perception changes. Lani, we have to go out to the people. When in Delhi, there was a discussion on end-of-life care done by Dr. Sushma Bhatnagar, in which the public were invited. And believe me, in the auditorium, there was a substantial number of people, very angry people. They said, what was the point? Why did you allow our whole family to plunge into debt if you knew that you could not salvage the life? The public perception will force doctors to change. We cannot change the attitude of subspecialists unless this is talked about. Lani, I would say, write about in the newspapers, do talk shows on the television, get people's voice be heard, and they will give the opinion. It won't be achieved in 1 year. It will take a long time. You can't do it alone. Get a lot of people together. This is what we are trying to do, and we have not succeeded yet. Some degree of success in Kerala, a little bit, but not much. But the National Cancer professional organizations have given the guidelines. And I think the social acceptance will be a major factor that will change the family's attitude also, and with difficulty, the doctor's perception. Sorry, Elani, there was no easy solution to that first question. Several hands have gone up. Sajjan and Srinivas, with your permission, shall I give the first opportunity to Abhijit, whose hand has gone up? He has not spoken.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So thank you. I just wanted to actually echo the same thing. I think this is not about knowledge dissemination. It's about a person's rights, and the hospital needs to be obliged to read out the rights of the patient or the family. So why is this not legally being done? I mean, I mean, people need to know their rights as soon as they are admitted in the hospital, from this.
Abhijit.
Yes.
One person by name John Hindon, he died a long time back. He died in the last century, maybe something like 30 years back or so. He wrote, "The dissatisfied dead cannot noise abroad the injustice they have received. Why is it not done? Because dead people have no association. Dead people do not vote. And living relatives are weak and demoralized, and there is no concerted effort." Which is why, Abhijit, you and I and everyone here have to be advocates for people who have no voice. The people who are suffering are voiceless. And if, as people with some help and functional vocal cords, if we don't speak out, nobody else will speak for them. This is not a priority for the government. They are dealing with the current crisis of making more money or exports and imports. They are not concerned with the dying unless the common man sees it as a priority. Man or woman sees it as a priority. Sorry for that sexist expression.
Yes, sir. Thank you.
And everyone has something to do here. Sajjan or Srinivas, whose hand went up first, please speak.
Srinivas.
Okay, Srinivas.
Sir, my question is basically, sir, when you ask the first question in this presentation, are you prepared about your death or this thing? Generally, we don't give any thought to that, sir. Personally, myself or the people whom we know, whenever we hear that word death, we get little bit panic and is it necessary? And as you rightly pointed out at the end of your presentation, that is what which is required, which is called as death literacy. So could you speak a little bit about that, sir?
Okay. I suppose that window has been muted. So, Srinivas, this Srinivas, this is not the way it used to be. It was not so all the time. As I said, just 2 generations back, in our country, it was mostly joint families. Death was familiar. I mean, in a way, it is absurd, death literacy. But that became necessary over these last 2 generations of nuclear families, where children grow up without seeing death, experiencing death. That is the problem, which is why this has to be relearned. This is a problem the world over. It's particularly bad in India. And there are many organizations working in this field, in end-of-life care, ordinary people's organizations. But in India, the movement is weak. What I must tell you, Srinivas, and everybody here, that is not for somebody else's task. When you feel that the rights of somebody who is ill are being violated, we have to raise our voices. We have to speak on their behalf. You will think you are too weak, but a 100 voices going up next year will rise to 1,000,000 voices the year after. That's the only way to go forward. Just being passive means abetting the cruelty. I wish I had an easier answer, Srinivas. Sajan?
Sir, just one thing.
Yeah.
Sir, basically, we plan many things about our future. We plan this investment, that investment, and everything. So, is there any process of every individual who has to plan his death or anything like that, sir? Is there anything?
As I said, in some cultures they were there. Like I told you about Bhutan. In Jainism, they used to discuss death, and there was even a process of fasting until death, which was sanctioned by religion. Hinduism, there was something similar called Prayovavesha. There are some things like that in our culture, which has died long back, not there anymore, which is why you have to start this literacy campaign for about that. Unfortunate. Our time is up. I'll take the Sajan's question and then hand back to the team, the coordinator. Sajan?
Yes, thank you. Basically, it is not exactly a question. I just want to make two statements on two different aspects of the talk. One is the later part, which is mentioned about how patients' wishes or their what do you call rights are not cared for by the doctors or the hospital, and then they just want to do what they want to do. Yeah, it's absolutely correct, and then it is unfortunate thing that we see all around us. Hospitals have become a part of making business rather than healing or caring and so on. So that is the reality. Like even I know cases even right here in Bangalore that even after a person was totally dead, the hospital kept them in ventilator, kept that person in ventilator for next 2-3 days just to make money extra out of it. So those, and during COVID it was like very. So that is one ugly part of the reality that we see. And then, as you rightly said, that there should be awareness, that society should come forward. And until there is a law prohibiting those kind of things, this will not change, because people are, becoming greedier and greedier every day. And, hospitals are at the top of the list. So that is one part of it. And then, like, there are many options available, for the society or the people to come together. Is like petitions can be, filed in or addressed to the Supreme Court or any of the judicial system, like through change.org and things like that petition. So, like, let's say there is lakhs or 10 lakhs of people sign that petition, covering this area. I'm kind of positive that the judicial system will look into it, and it can become a law as well. That is one side of it. The other side, the early side that you discussed, is like that I coming back to the expectations of life and end of life and death and things like that. What I understand based on my Christian faith is that like when we see human life, which is 70, 80, or even 90, that is actually a very, very, it's like a snap. When we compare the whole of eternity, or like a blink of an eye, basically. So as you rightly said, it is very good and wise for people to introspect and reflect on what their life is all about. What at the what is the what if the end comes, or when the end comes, what happened, and so on. So basically, to reflect it either multiple times or at least once in a while, it is good, so that we can plan and make our lives more meaningful, and our priorities can be set right. For example, if a person knows that he is going to die or she is going to die within 2 or 3 days, their whole priorities will change, like so similar to that, if we, so it is good that we plan it according in that order, that way. And then, not to be worried. I see that, if we keep, if we are fearful that, oh, I'm going to end up in ventilator, that kind of a thing, that itself will add to the stress, which is not a necessary thing. I myself is a optimistic rather than a pessimist, saying that I will die a good death rather than a miserable death. So I think we should not panic. We should not totally get stressed out there thinking about it, but rather than do what is given to us with our life, best we can, taking care of our health. Like any other things in this world, if we take care of it, it will do its work more better, and it will prolong its whole duration. So things like similarly, I think the best we can do it and leave the rest to God is my approach, and then my input for that topic.
Thank you for sharing your perception. Sajjan, thank you very much, everybody who participated. And I'll now hand it back to the coordinator for the case presentation.
Sir, there is one more comment left in the chat box from Anima, like end of life care is not in the curriculum.
It is now, Anima, from 2009, 2019, the medical students joining the medical college have pain management, end of life care, and attitude, ethics, and communication in the official curriculum. So that is new. How many years will it take for the faculty to learn it so that it can be taught? That's alak baat. But it's there in the curriculum now. Thank God.
Thank you, sir. And we are moving to the case presentation. Today we do have a case presentation by Dr. Rajiv. Doctor, please take it.
Thank you. Will I be sharing a PowerPoint from my side? No. Okay. Thank you.
Dr. Rajiv, where are you from?
Sir, I am actually from Kerala, but right now I am in Andhra Pradesh.
Okay, thank
you. Good evening. Good afternoon and good evening, everybody. Respected Rajagopal, sir. I am indeed happy. It's actually a high point in my this short course where I am getting a chance to present the case. It's actually not a case history. It's rather a case study in front of you, so that I can get some of my doubts cleared, long-standing doubts cleared. In fact, part of the doubts were cleared by your talk because the topic is kind of aligned with the today's topic of presentation, end of life care. I had a lot of doubts with regard to this. So I'll move on to present the case study. I'm going to present a bit of old case study, and the person in question is a 79-year-old male who was, like sir was telling, nobody can live forever without any illness and all that. Some or other problems will come up. Diabetes mellitus, which was added, complicated with neuropathy. Then there was hypertension, which was there for a long time. COPD, which was worsening, and then finally it came to a point pleural effusion became a tormenting situation finally. And the subject in question was a retired doctor who knew everything about whatever he was going through. So there was no question of convincing him against any of the pathology behind it and all that. So we won't get into the medical aspect of it in line with the course content. Seniorji, move on, please. Yeah. So there was this long-standing diabetes mellitus and hypertension, and treatment was actually working rather well. But there was one episode of hemiparesis which happened, and in half a day it got cured without much of intervention, in the sense, they never had to go for any invasive procedures and all that, which happened 2 years before this, around 77 years of age. Diabetes got associated with neuropathic symptoms, and lack of balance became a problem, especially while walking. He was finding it difficult to walk in a straight line. And when he was admitted for managing this particular condition, suddenly the ophthalmologist friend found out one eye was without central vision, which the patient did not or was not very much aware of. And then it became a shock again, sudden finding that one eye was almost centrally blind. And in between, the patient had also hidden the fact that he had a road traffic accident while traveling on a scooter, around 75 years or something like that. And it had later CT scan actually showed the resultant cortical atrophy. I don't know whether it is because of the accident or the progression of the comorbid conditions. And there was prostatic hypertrophy, which was not intervened again, and it was associated with urgency. So what happens is we'll suddenly get up and rush to the toilet, and then will fall, and then once fallen, getting up became progressively difficult more and more, which required assistance later on. And the long-standing restricted lung disorder also brought on by constant years of smoking, and the bouts of coughing was particularly bad in the morning, and eventually it advanced to the stage where pleural effusion required him to get into inpatient care, and there was no definite pathology which was discernible, like tuberculosis or malignancy. Doctors there could not prove any particular cause for his pleural effusion, which was drained repeatedly. Moving on. The inside part of it is like patient was aware of the diagnosis, is insight about the situation, and he was aware but very unhappy about the complications until again at the stage of advanced stage. And then the palliative part of it unofficially was being taken care of by a small clinic. We had 2-3 staff was appointed under him, so they used to take care of his palliative needs, not very scientifically as I understand. And the family was aware of as much as possible about the conditions, and was aware of the condition and the prognosis also. But the physical limitation, which was also like spouse was also advanced in age, so that physical limitation restricted her from taking care of the patient in a perfect way, but the staff used to help out. Moving on. The family comprised of, the whole set of families, like 3 children, married and all that. And then there was, the patient was living with own spouse and one of the daughters. These 3 were actually living as one separate unit. And the interactions with the next slide, please. Interactions, in between. This patient actually had a very independent, strong personality. Like we were talking about, the reality of death and all that. He never accepted the fact was, the age was advancing, and the continued use of smoking and even alcohol, until he could manage to get it purchased by other people and all that. He actually continued the use in spite of, family members being totally against it. Spouse was trying to be supportive as much as possible. And he was of a very angry disposition, and he will not tolerate anything, so easily. And even the diabetes related food, this thing and all that, he used to go off track and all that. And then function started deteriorating. And that was also associated with lack of awareness of the same, because he started losing his sense of reality. He was not happy with the doctors who wrote his complaints as untreatable, especially a neurologist who said, neuropathy cannot be, it's kind of, hopeless, you have to live with it or something like that. And he was himself treating the diabetes and hypertension towards the end, until he got admitted, where the doctors came in and changed the prescriptions and all that. And that 75-year milestone looked to be watershed in his life, where deterioration started happening much faster. But in between the cataract, there was also cataract, which got operated upon, but already the eyesight was compromised by the diabetes, which I was explaining earlier. Respiratory situation also rapidly deteriorated, and he became bedridden. And during that bedridden he started suffering multiple falls while rushing down. He was very independent, he won't depend upon anybody. So he'll just fall down, and then somebody has to lift him up and put him back on the bed and things like that. He refused anything like urinals, anything which brought on the idea that he's disabled. Totally used to upset him. So he was totally against all that kind of interventions by the spouse and the supporters. Pleural effusion was compounded by the problems. And finally, there was a tough point in life where doctors asked the spouse regarding the admission to ICU. And then they had a discussion. At that time, it was a bit difficult actually, but spouse said no ICU. In fact, the doctor, sir, like you commented, the doctor asked, whether you want to be with a see him coming out alive. You will only see him coming back as a non-living person. So do you want to be with a person, or do you want him to go inside the ICU? Spouse at that time, much against the opposition of other people and all that, said that, okay, better be in the room. And then finally, that's how things ended. Moving on. Yeah, this is the eco map. I already found out, explained about these kind of things and all that. This was the kind of relation which I have mapped out, from the story. This is the eco map which I've made. Next. Socioeconomically, being a retiree, pension was not an issue. And then he was very restrictive about the money-related information. He'll not share anything with the spouse or the family and all that. He also incurred in that advanced age, he also incurred a hefty loan, which he could not pay it back, and then that became a bit of an issue later on. And then he also got the spouse into confidence. That also became a little bit complicated, ending up in some court cases and all that. And being independent in money deals and all that, spouse could not track, what the position was, which caused complications, like I was telling. And the spouse was totally dependent upon the employees of that clinic, what I was talking about. But she was very resentful about the way they were actually mismanaging the money of that income generated by the clinic and all that. And the net expenditure was actually in the red because of these issues and the conflicts of interest which the people had in terms of his situation and all that. And then also led to a friction. Employee said, you are taking him to his death. You are giving him a death sentence and all that by taking him to the hospital. The situation was mismanaged and all that. So it created a lot of friction between these two entities, as it were, the family as well as the supporting staff. So it was not exactly palliative, as I mentioned. Next slide, please. Psychologically, the frequent falls was very problematic for the spouse, and the care also suffered. When he was bedridden, bed sores started, and they could only do so much in doing so much about it. And they were living in an old house in spite of the loan which he took, and he made a new house. He and spouse was refusing to move into that house. So the lighting was poor. He had this accidents because of the old construction and all that. And he was not accepting the disabilities and all that, and he was very much disturbed about it. And he was also, like I said, continuing to use alcohol and cigarettes and all that. And then the family's ambition was, they wanted to see him live for another 10 years, but 79 years became a very tough year for the patient as far as he was concerned. And the stubbornness also affected the social security as offered by the professional organization, which was in touch with them. But the colleagues were very supportive. So there was some amount of social support also happening simultaneously. Next. So this is a grid which I made again from the same story which I'm talking about. Physically, being a chronic diabetic, pain was not an issue. Physical impediment was an issue. Psychologically, the shock of being diagnosed with all these complications led to a lot of conflict within the patient, and the atrophy, probably cortical atrophy, made him lose his insight to a greater extent towards the last part of this case study. And financial mismanagement and the friction which happened between employees and the family created social issues and probably economic issues also. Support from the relatives. Spiritually, the patient himself was a staunch atheist, while the spouse was totally devotional. They were opposite poles. But towards the end stage, I think, patient was trying to understand, what the spouse was actually trying to achieve. And he needed inner strength from the spouse, indirectly, he also probably became spiritualist, my understanding. Next. So my questions are to the group, as well as, Rajagopal sir is.
Dr. Rajiv, what's your own answer to the first question?
It should be, sir. Pain
Absolutely,
is not
absolutely, no doubt about it. Palliative care is not only for pain, any kind of health-related suffering.
But
Okay.
somehow palliation was considered to be like a pain relief and thing.
Yeah, many misconceptions. Some people think it is only for dying
The
people.
question be
Some
like,
people
sir.
think it is only for morphine.
Yes, sir. Yes, sir. Yes, sir. Exactly, sir.
Okay. Second question.
Like, sir, you said most of the doctors will get admitted into ICU. So community cannot get into the management of it, because you have the wherewithal, just get admitted, just leave the hospital to take care of the remaining things and all that. So community refuses to get involved, or these doctors community doesn't allow the community to get involved. They'll say, no, you don't know anything about it.
Maybe.
And sir,
You can't always generalize about doctors or communities. It's very much depend on the person and the community. Yes.
Sir, again, the long-term admission to hospital, like employee, the people who were taking care of him at home, the discussion started today with that really, like, where do you see your own death? People think that they are going to die in the home, but it almost becomes inevitable, because once you become dependent, you will be carried to a hospital, and then long-term admission becomes happening. And if you don't admit also, you get blamed. Even if you admit also, you get blamed and mismanagement and stuff like that.
Dr. Rajiv,
Sir.
This is a usual problem. Like very loving son and daughter decide that the father's wish should be respected,
Sir.
And agree to keep him at home.
Sir.
And somebody comes over and gives palliative care. Let's imagine. This happens all the time. Cousins, uncles and aunts all blame them for not spending money. The uncle comes and asks, is he not your own father? So this can be very hurtful. And there we come in early. When we do shared decision making, when we sit with the patients, if possible, or at least with the children, we tell them this is going to happen. At some point, you will have to take a firm decision that you will not do things to him for the sake of somebody else's feelings. He is most important, right? His autonomy, that's that person's life. And we will do the best for him, whatever others may feel. You will not argue with them, fight with them, but you will do only what is best for him. That early discussion helps people most of the time. Sometimes, no. I'm just, no, I would have engaged all the group a little more, but I also see that we have only 8 minutes more. So in the next one, if the employees, others, they may be genuinely supportive, they think the woman is destroying his life, or they may have vested interests. Dr. Rajiv, as a palliative care person, is there anything that we can do?
It goes beyond the medical call, sir. I mean, like, we have to get
medical problem. Is that a health issue or no?
Social health issue, yes. Socially
yes.
Health issue, yes.
And we, I thought, agreed that palliative care should be for all serious health-related suffering.
Sir.
Here is a health-related issue. We can do two things. One, we can say that that's your own problem. We are not coming into it. You resolve it. But when a person's rights are being infringed, in our team, I am proud to say we have 8 doctors, but we have 12 medical social workers. They try to get some consensus if possible. And we have a volunteer lawyer activist who will help if necessary. I'm not saying that in every case we will jump into all the legal issues, but we will not allow a total injustice if it can be helped. So, Dr. Rajiv, you are working in an AIMS institute.
Sure.
You are bound by the institute's rules. These are our limitations that we have to accept. I used to do precisely these things, like just not getting involved in legal aspects at one time, but now we are stronger, supported by the social workers, usually supported by the local self-government institution like Panchayat or corporation, and with a lawyer activist. Sometimes we get involved in this, like if a person's property is usurped by his own children, perhaps. They may have their own reasons. He may have been a bad father, and then he is thrown out. We will our lawyer usually manages only by pointing out, if this happens, we will invoke the law. Legally, the man can reclaim his property from you. We are going to proceed. And then things get patched up. We never go to court, but by invoking the law, we are able to usually resolve issues. But I'll also admit, I am doing it because I am here in an NGO, supported by a lot of people. In my first 15 of years of palliative care, I would not even touch those problems because I didn't have the capability. So what am I saying? If there is an element of suffering there, if we have the ability to help, we will. We also realize that we are not only human beings, there are limitations to what we can do, and we will have to work within those limitations. If you are in an institution, you will have to work within the limitations of the institution's rules. No doubt about it.
Thank you, sir. Remaining questions are related to the previous ones only, like in a way. And your class was already covering all these aspects also.
Therapeutic trial for living pleural effusion hasten the end of the patient.
That was the accusation, sir.
Yeah, but very, I mean, again, if somebody is breathless because of pleural effusion, we have the moral responsibility to relieve it.
Sure.
It would be good to get all parties to understand it so that these accusations do not happen, but they happen sometimes. But we will try to do the right thing for the right reason. Social adaptation of the family to the patient, we could have tried,
Yes, sir.
knowing fully well we will not always succeed.
Sure.
But in that context, Rajiv, I have to say something which everybody may not agree with. This man has been drinking all his life or through many years. I suspect that much of his suffering was because of alcohol withdrawal and tobacco withdrawal. Was it fair?
Yes, sir.
For him, alcohol is a needed medicine. I'm not saying that get him as a bottle of whiskey every day, but enough to relieve the suffering. I actually have colluded with a patient's mother to give. She will carry one drink in her bag and give it to him in the hospital. The hospital where we were working would not allow it. This was a conspiracy between me and the woman. She brought it for the son because she could not imagine. Most suffering cannot be worse than a withdrawal symptom in somebody in acute withdrawal. That's horrible. So that's another thing altogether. Many people will find it hard to accept it, I know, but I think it is cruel at this point of time, at this point of suffering, to try to withdraw whatever he is addicted to. Again, Rajiv, what we can do in that situation may be very limited. We may not be able to do much. We may have to watch. We may only be able to give him more benzodiazepines to reduce the suffering. But what we can do, we will do. Hey, were there a couple of more questions on the screen?
2 more minutes.
We have 2 minutes more. Okay.
Like superstitions, moving to the new house, because of vastu issues and all that.
Listen, he was in no power to do what he wanted to do. The woman was in charge. He was possibly not even competent to take decisions. Whether it's a superstition or not, it is primarily that man's decision. If he is competent to take the decision, if it is not, if it's a woman's decision, and who are we to judge what is superstition and what is faith?
Thank you, sir.
So your SFM is social, no, CFM is community and family medicine.
Family medicine, sir. Yes,
okay,
sir.
Okay. So glad to meet you.
Thank you,
Rajiv.
sir. I'm so happy that you were in the session and then I could talk to you, sir.
We have 1 minute more for anybody with a desperate question about this presentation that has just been made. I was almost expecting somebody coming and attacking me about that alcohol business. Virtual meeting, that's one advantage. You will not get manhandled. So back to you, senior.
Any comments or questions or doubts you have? I think no. No comments.
Rajiv and Rajagopal, well done. We stuck to time.
Yes, I think. Thank you all. Special thanks to Rajagopal sir for being here with us today for this wonderful conversation we had with all this group. And I think those participants made it beautiful, more beautiful, interactive. Thank you all for being here today with us. Apparently, this is our second last class. One more session is pending. That is postponed. It will be happening on the next Wednesday. Thank you. We'll see you on the next session. Bye.
Bye, everybody. Good day.